Well, hi there, it's Mayo Friedlis. I work in Washington, D.C. at Stem Cell Arts, and I'm going to present a workshop as best as you can visually, virtually. Introduction to IROM for musculoskeletal healing. IROM is Interventional Regenerative Orthopedic Medicine. It's what we do, and this is sort of a broad overview, a chance to learn some of the considerations, some of the issues involved in starting up an IROM practice. I've been in practice many years and I have learned a number of things, which I'll try and share with you. So the first step is, why bring regenerative medicine into your practice if you're considering this? Why did I bring it in? Well, I was frustrated with the lack of ability to fix my patients with the common stuff that I had, cortisone shot, physical therapy, medications, exercise programs, even radio frequency and things. And, it wasn't enough for me. I wanted to do more for them because these were treating their pain nicely, but it wasn't really fixing the problems, and they kept coming back. And I stumbled into a course on regenerative medicine, actually prolotherapy, and it changed my outlook. Once I treated a few patients with that and learned I could actually fix things, then it became rather addictive. And I learned more and more and became, somebody whose whole career is about regenerative medicine. I suggest you start with prolotherapy, and I'll go over the reasons why. So let's talk about how prolotherapy works. Before we can do that, we need to talk about how normal healing of wounds works. Something I never knew was how we actually heal normally. There's an inflammatory phase, a proliferative phase, and a remodeling phase in the body, no matter what's healing. So there's an inflammatory cycle. So if you've done that, you sort of shut it down. So prolotherapy restarts that process, and it does it by chemically and physically stimulating the tissues, and you get the release of these growth factors and the normal cascade of healing. That's how it works as far as we know. The indications, patient selection, well, these are patients that have chronic problems, chronic strains and sprains, neck, whiplash injuries, neck sprains, aging necks from some degenerative facet disease, lumbar spine issues with sacroiliac pain, and, discogenic. What you don't understand until you start doing regenerative medicine is that a lot of these pains and problems are related to ligamentous insufficiency and microinstability of the structures. And by strengthening the ligament structures and the facet and other joint capsules, you stabilize that structure, and then all the muscle spasm goes away and the patient feels great. So that's all part of sort of what we teach in regenerative medicine, is stabilizing structures and treating the underlying problems, not just treating the one that hurts. So, basic prolotherapy injection is just, in a 5 cc or 10 cc solution syringe, 3 cc's dextrose, 50% stock solution, 2 cc's lidocaine, 5 cc's saline. And that's a 15% solution, which is safe. You're really not going to hurt anybody with that. So it's a great solution to learn on. We use stronger solutions sometimes, but only for specific applications. The results of the treatment are often curative. People with lower back pain that they've had for years and years are fixed. Same with neck pain, same with shoulder pain. So it can be mind-blowing and life-altering for your patients. And insofar as that happens, you get sort of addicted to treating people this way instead of with the standard ways. PRP is often used as well. PRP has the same, prolotherapy and PRP have the same endpoints. They both do the same thing mainly to patients. PRP is stronger, so it takes less sessions, but they both can do the same thing. So the advantages of prolotherapy: simple to perform once it's learned. There's no equipment or preparation. You just draw it up and inject. You don't have to, have the patient come in for a blood draw, and, it's a lot simpler to do. As a method of treatment, it addresses the entire organ system. So, if you're treating a shoulder, you treat not just, the torn rotator cuff, you treat all the capsular structures, the ligamentous structures, you stabilize that shoulder and treat the painful structure. And in so doing, it's going to give a much more long-lasting fix than just, PRP. Some patients respond to prolotherapy, but not to PRP, and vice versa. 5 to 10%, I think. But they're both great treatments. So let's introduce PRP now. PRP is when you actually put growth factors in play at the site of the injury. Growth factors are basically, biologic things that turn on our healing processes and interact with that healing cascade in a normal fashion that your body would want it to do. So we're just using that normal healing cascade, but we're dumping either cells or growth factors in to stimulate the start of it. So we use that to basically fix cartilage, ligament, tendon structures. Growth factors are produced locally at the site of an injury, and if we collect them from your platelets and introduce them, we basically just start that healing process all over again. Growth factors are released from not only platelets, but also macrophages, neutrophils, lymphocytes, platelets, and fibroblasts, and they bind to, how do they work? They bind to cells and turn on that cell. So, essentially, let's talk about platelets. Since we're talking about PRP, platelets are released from these alpha granules on the surface of the platelet, and that's called the activation of the platelet. These alpha granules release specific growth factors, probably about 100 of them, but the main ones are the ones listed here that do specific things. And if we take and collect the platelets from the blood, extract them from the blood, and then inject them, then we get all these things released. What do these things do? Well, they bind to other cells like fibroblasts and stem cells, and they turn them on, and they actually change their genetic expression and make them do work. And they actually reconstruct tissue, and they build new tissue, and they spit out collagen, and they create new structure. So that's the magic of the body, and that's, it's harnessing that magic that we're able to do. So yeah, we talked about all that. So PRP delivery considerations. If you decide you want to do some PRP, you have to make a decision. Are you going to do this using a proprietary machine, which I recommend when you're starting? It's consistent, it's reproducible output, it's safe because they're pretty closed systems, and they're easy to use. They're somewhat expensive because you have to buy kits from the company to do this, and you have limited options because they only produce so much product. Usually, 5 to 7 to maybe 9 cc's of 5 times concentrate PRP. And, if you're looking at larger structures, they have their limitations. Resources for you: MSite, Harvest. There's other companies out there. Do some research on your own. The other option is you do it by hand. You create a lab in your office, and you have to, it's a lot cheaper to do that, to use, yellow top or red top tubes and spin them in a centrifuge and extract the platelet, the buffy coat, and voila, you got PRP. And the advantages are you can create any amount you need. You can create 20 cc's of PRP. You can create any strength you need, 5x, 10x, 20x. You can customize it for that patient, for that problem that the patient has, for the age of the patient, for the size of the problem, for the severity of the problem. having your own lab and laboratory technician allows you to do that. I would point out it's a lot more risky. You know, you have a lot of opportunities to interact with that sample and contaminate it. And you have to have good protocols. Otherwise, what you're doing is very risky. You could be injecting a patient with a contaminated sample. And you got to understand what you're doing. You got to have good training for your lab people. And you have got to have good consistency. So 2 options available for PRP. Indications for both PRP and prolotherapy: rotator cuff tears, capsular tears, epicondylitis, wrist problems, hip problems, you know, greater trochanteric. Never seen cortisone treat one of those successfully, but PRP is great. Patellar tendonitis, Achilles, et cetera, basically anywhere in the body where you have a strain or a sprain, a ligamentous or a tendon or a labral issue, mild arthritis, things like that. So comparison, prolotherapy is a lot easier to prepare. It's less painful to administer and afterward. It works faster. So if you have somebody that's on a time frame, needs to get better faster, prolotherapy is actually a better option than PRP. You can repeat it sooner, like, you know, a week or 2. It's cheaper. You can treat wider areas, and there's less chance of infection because you haven't manipulated their blood. PRP has advantages too, and disadvantages. If you go into PRP, it's a new process for the office. You have to draw blood, you have to handle blood, you have to purchase kits or set up an office. So, you know, you have some disadvantages there. More painful to administer, maybe by 20%, and afterward, you know, twice as discomforting. And you often don't see results until 4 to 6 weeks. You need a lot of material to work with sometimes, and this won't give you a lot of material. So it's, you know, for larger projects, it's just not going to be suitable. It is, however, twice as powerful as Prolos, so you can get by with less sessions. Typically, a shoulder will take 4 sessions of prolotherapy, but 2 sessions of PRP. Same with an ankle, same with a knee. A back might take 6 sessions of Prolo, but only 3 sessions of PRP. So if you start with PRP, you know, it's often you'll have blinders on because you won't have learned the approach for prolotherapy. You'll see only the MRI or the ultrasound lesion, the tear or the, you know, separated tendon or whatever. And you won't go after treating the whole structure. So that's why I suggest you learn prolotherapy first. You'll have better outcomes. Limited by the volume of the prep, by necessity, only limited structures will be treated because you don't have that much sample to work with. This limits outcomes. And it's not great for small cases like a thumb or a finger because it's expensive. If you start with Prolo, you'll learn to address the entire area first. It's easy to do the Prolo and then just add the PRP to specific ligament or joint. Better outcomes using both. What do? You know, I have access to Prolo, PRP, stem cells, and I never do a stem cell without doing PRP with it to treat the ligamentous structures. And I never do that without PRP to add the growth factors to stimulate the stem cells. So you learn to use all of them. They all have a place, and don't skip one, just learn them all. So I use them all, I get the benefits of each. And when you use Prolo and PRP, you'll get better outcomes together for things like osteoarthritis of the knee or rotator cuff tears of the shoulder, etc. Stem cells, what do they add? Well, they're excellent for larger tears or tendons or ligaments, labral tears. Basically up to 1 centimeter you can bridge with stem cells. Indicated for osteoarthritis of any degree in any joint. While you can get by with lesser things, if you're looking to mitigate the progress of that arthritis, then stem cells is the way to go. It's going to be the most powerful treatment to slow down the progress of that arthritis. If you're looking for pain control only, symptom control, PRP, prolotherapy are great. You'll just have to repeat them more often, every year, 18 months or so. But they're all great for these treatments. For the spine, they can be used for disc pain and disc treatment for degenerative disc disease. It's not a magic bullet. It doesn't make a disc nice and doesn't restore the height. It doesn't restore the morphology of that disc. It might add a little water content, but really it's not clear that it works better than just putting platelets in there. But stem cells are definitely helpful for treating musculoskeletal disease. So considerations for stem cells, it's a much larger procedure, but there's more opportunity to help people. You have to decide fat versus bone marrow. Fat's off the table because the FDA doesn't allow fat-derived stem cells. It's considered more than minimal manipulation, so not legal to use. So bone marrow concentrate is basically the only thing available now. Amniotic products, you should know by now, are not stem cells. They are amniotic products. They have growth factors, but they don't have cells. If you use stem cells, you'll need PRP as well in order to activate them. So you have to figure out how to draw both of them and generate both samples. A targeted injection works better than just dumping them in a joint. So get proficient with guidance, particularly ultrasound. And you really shouldn't be doing stem cells unless you're willing to keep up with the science and, all the time knowing that you're doing the best possible treatments on people. There's so many developments happening. If you're not willing to stay up with it, you stand the risk of doing something that's really not the best. So example treatment protocols, I'm going to go over 3 of them real quick, just so you understand how things work together and that using all of them can that's where you need to think about. That's where your head needs to be at. So the first one is low back pain and disc pain with or without radiculopathy. And the second one, rotator cuff tear with or without osteoarthritis of the shoulder. And knee osteoarthritis with or without meniscal tear. So let's talk about the knee. We have a 64-year-old female, medial compartment, grade 3 osteoarthritis with medial meniscal tear. She has full range of motion and no angulation of the knee. And that really looks like a good candidate. The fact that she has no angulation and has full range of motion portends a good outcome no matter what her MRI really looks like. So those structural components seem to be more important than the grade of the arthritis in outcome. So starting first with the joint surface, let's say you have grade 1 osteoarthritis and cartilage damage. You could use PRP or stem cells for that. Grade 2 to 4, I would probably pick stem cells just because it's more powerful. Patellofemoral disease is a much more difficult condition to treat, so I would use stem cells for that. Meniscal problems, most tears without instability are going to be just 1 or 2 sessions of PRP. If you have a larger tear, then stem cells might be a good option. When we're treating meniscus, we always have to worry about stabilization of the meniscus so that you can mitigate the future and further tearing of that. And that involves treating the coronary ligaments, and prolotherapy works great for that, though PRP can work as well. MCL, LCL tears, prolotherapy works great for that. For laxity or for sprains or strains, small tears, PRP, you can use an amniotic construct for something like that. In addition, larger tears, stem cells, or PRP plus amniotic construct. ACL strains, PRP will treat those very well. Partial tears can be done with stem cells. There are even specific protocols for treating complete tears with stem cells. And, you know, the medial patellofemoral ligament can be treated with PROLO or PRP. And, you know, if we have serious tracking issues and you're doing a patellofemoral problem, then, you know, you'd use stem cells on that too. Quadriceps or patellar tendinopathies work well with PROLO or PRP, depending on the severity. Medial knee pain, post-op or recalcitrant, you know, to treatment. Often you can hydrodissect the saphenous nerve and get nice relief from that. So, or the other geniculate nerves. Moving on to the spine, here's a spine which has, you know, some degenerative disc disease and some facetogenic disease, and, you know, there's also some radiculopathy. So let's talk about all those issues. Here's a little pressure on the nerve root. So discogenic pain, we can use a platelet releasate or lysate as an epidural. These do great for treating discogenic pain or tears, you know, annular tears in the disc. PRP should, if you're going to do that, you also have to stabilize that segment, and in fact the entire lower back. And we would use PRP or prolotherapy to superior, adjacent, inferior structures, including facet joints, intraspinous, supraspinous ligaments, sacroiliac joints, sacroiliac ligaments, iliolumbar ligaments, all designed to stabilize that and take some of that pressure off the disc. If there's radicular pain, we can treat that with platelet lysate or releasate. And of course, we want to be careful we filter that since that's going intraspinal. And that can be extremely helpful in people who have continued radiculopathic pain after surgery, or they've, you know, blown their 3 epidurals with cortisone and they're not better yet, and their next step is surgery. This often will give dramatic and sustained relief and allow them to skip surgery or recover from surgery. Facet pain, if you have some degenerative disease, then a high strength, high concentration PRP, like 10 times, 12 times concentrate, or the use of stem cells can be helpful. And again, we want to treat the adjacent, superior, inferior segments with regular strength PRP or prolotherapy. SI joint sprains and instability, you would want to use prolotherapy or PRP to treat the joints and ligaments, including iliolumbar ligaments and facets up to the level of L4-5 in order to stabilize, you know, the lower pelvis. Here's just a chart that sort of tells you what structures you can treat with what, and, you know, you can sort of review that on your own. The shoulder, rotator cuff problems with or without osteoarthritis. The rotator cuff problems can be treated with PRP or stem cells depending on the size of the tears. Sometimes you might want to use a biofiller, you know, some amniotic product that can be used to fill the gap if there's a fairly sizable hole in the tendon. Retracted tendons won't do well if retracted more than 1 centimeter, and only if you're using a really high quality stem cell and a graft. If it's retracted more than that, see if you can work with a surgeon to pull that piece over and then treat it with, you know, the surgeon can pull that retracted piece. A lot of surgeons won't attempt that, but some will. And you can pull that over and then treat 3 weeks after surgery with stem cells and get a much better healing there. But whatever you do, you want to treat the whole shoulder, so you're going to be using prolotherapy to the anterior and posterior capsule, inferior glenohumeral ligament, AC joint, glenohumeral joint, all of those structures. The glenohumeral joint, AC joint, arthritis. Stem cells is the best, but PRP can certainly help. And again, we would want to treat all the other structures as they can be pain generators as well. And you want to make sure we have good stability of that shoulder. Stabilizing the joint will help to slow the progression of the arthritis, theoretically. Labral tears respond really well to PRP if smaller or they're older people. You know, young athletes, they will respond to small tears with PRP or stem cells, but larger tears will need to be treated surgically. So you really, you know, the activity of the person is important. If they're pretty much couch potatoes or weekend athletes, they often will get by with biologics, even with a larger tear. But, you know, people who are throwing athletes or you know, people who need their shoulders may need surgery to stabilize. So, yeah, so whatever you do to the labrum, you also have to stabilize that shoulder. So you have to treat the capsule and all the other ligaments and either PRP or prolotherapy for that. And again, I put it in a chart form for easy reference for what you would use to treat each kind of structure found in the shoulder. So how do you add regenerative injections to your practice? There's a lot of considerations that are, you know, some technical, some business that you would like to know about before embarking on this course. So first of all is your training. What do you want to treat? The, you know, what structures you will wind up treating, you need to worry about what training you need. What training will be expected by the community to do this? What would you expect for yourself? If you were going for treatment of your shoulder with stem cells, what training would you want that physician to have? Ultrasound, very important for all peripheral joints, nerves. You can't treat these things well unless you really have good ultrasound skills. I put down some resources for you. Obviously, a lot of people having courses, but here's 2 good companies to learn from. Fluoroscopy, if you're going to do the spine, you have to have fluoroscopy skills. Doing it with ultrasound is not as good, and you won't be able to treat it as well, and you won't be able to treat the important structures like the disc and the nerves. That's not standard of care to use ultrasound to do an epidural. You can do obviously a caudal, but you know, the rest of it is just going to be sort of substandard. And here's some resources for you to learn, you know, fluoroscopy techniques for you. The IOF probably the best at this point. ASIP is also good. CIS will teach you if you already are interventional spine, I think, but not really if you're like not that, you know, your sports medicine. I don't think they will teach. Think about risk management. Understand the standard of care in your community. Understand that what you're doing, others are not doing. Understand the harshness of your medical community. They can literally crucify you, you know, if you're out there too far. So you have to sense where your community's at with the acceptance of these things. It was a lot worse for me when I was starting out because they literally thought this was voodoo witchcraft. And now you have many more people doing biologics, so you're not out on as thin as a limb as I was. Pick procedures that are safe for you, considering your specialty and training. So you're doing interventional spine work on the disc. You know, just picture yourself in court. Well, doctor, what training have you had to put a needle in the disc? And you better have a good answer because, you know, these cases have a way of moving against you in a very hurtful way if you don't have good answers for those questions. So complete adequate training is important. And then do extra training so that if you're on the witness stand, you can say how well you're trained and why you have the moral authority to be doing that particular treatment. Set proper expectations with the patients and documenting these discussions in your medical record. You know, it's not enough just to verbally say it. You have to document what you said. Informed consent. Your informed consent needs to be thorough and, you know, cover the issues of doing biologics, that they may not respond to the treatment, that, you know, some people don't, and they may have no response at all, that, you know, they're doing something that is, it's not experimental anymore, but it's not in the usual course of using those products. So it's you know, you have to tell them the story. Have good record keeping. You know, what gets you in court is your lack of ability to document what you did. If your record is messy or it just is not easily followed, you know, you're on thin ice. If you quote outcomes to your patients, make sure they're your outcomes. You can't take, you know, you read on a website or you went to a seminar and you heard that stem cells done by so-and-so, he said they were 65% improvement in pain and function. You can't use that data. It's not yours, you know, without attributing it to someone else. You can't say, you know, you have 80% response to stem cells unless you do. You know, you got to be able to prove it. Otherwise, it's just your opinion, and you have to make sure the patient understands, you know, the nature of what you're telling them. And be ready to mitigate problems. If somebody has a problem, they didn't get better, they spent all this money, make them happy. Because if they're not happy, you've done something that's not the standard of care in your community. And, you know, when they go to the medical board and they go to a lawyer, you know, you're not going to be sitting pretty. So you got to give them your money back, give them the money back. If you have to do more treatments on them for free, do that. If you know, just do what you have to do to keep these people happy, because, you know, standing on ceremony, standing on, well, they're not right, you're right, it's just not going to win it for you in the end. Always get questions, you know, do you take insurance? You know, I've always decided a long time ago that it's better to take insurance. Some people like the fact they don't have to mess with it, but I find that I get a lot of people walking in my door because their consultation is paid for, and that I have other treatments that insurance does pay for. And, you know, these people would never walk in your door otherwise. And once they do walk in your door, you have the opportunity to sell them on regenerative medicine, which is going to be better for them. But if they're not in front of you, if they've never walked through your door, you won't have that opportunity, and you have your opportunity for patients is much thinner and leaner, because it's not a lot of patients that will go to a doctor that doesn't take insurance. There just isn't. So, you know, the con is that you have to be prepared to provide treatments that are covered by insurance. And if you do cover something that isn't covered by insurance, you have to take what they pay for it. So diagnostic blocks, I'm a big fan of them, even doing regenerative medicine. Why? Because it proves to the patient what structures need repair before they invest the money. This helps when you're trying to convince them. You know, if they've seen, okay, I've injected the sacroiliac joint and, oh my God, that took away 80% of my pain. Yeah, it's the joint. Okay, we can fix the joint. We can put cortisone. It's going to be temporary. We can use platelets. It's going to be long-term, probably lifelong, you know, and that's a sale you can make. So I always provide conventional and regenerative options to them with the pros and cons of each. And regenerative always wins if they can afford it. It's also safer from a legal perspective as well, that you've offered everything and the patient actually made a decision to pick the regenerative after being offered standard of care. Where do patients come from? Well, they don't come from other docs, as you may think. They're not aware of these treatments. They're not comfortable recommending, the other doctors are not comfortable recommending cash treatments to their patients. Their patients are complaining about their copays, so they're very leery and sensitive about recommending something that's not covered. And they're also competitive in their outlook towards you. They can't stand the fact that you're getting paid cash when they have to go to the insurance companies and beg. And they're also afraid of the medical legal risk. If they send somebody to you for something that, is new and, that patient runs into a complication, they're afraid that they're going to come back at them for sending you. So you won't get referrals from other doctors. They do come from other patients and word of mouth. So you treat one patient and they do well. That patient tells other people, so that helps. They come from ads you placed about these treatments. You have to be comfortable placing an ad. There's other get the word out tactics. We'll talk about some of those. In other words, though, in short, you have to find these patients. Marketing your practice, well, everything counts. Let's start with your office. If you walk into your practice, is it a place that is a concierge environment? People who are paying cash for procedures want a concierge environment. They don't want a place that looks all run down and dirty and needs repair and disorganized. They want a front desk that treats them with respect. They want to be treated like a special patient, as if you were going to a plastic surgery office or something. They've got that down. So sit in your office, sit in your lobby and see what you feel like. Do you feel like a special patient, or do you look around, there's dust bunnies under the chairs and the upholstery is worn and the ceiling has spots on it, or needs a new paint job, or the office staff is acting unprofessional? All those things. That's why I say everything counts. And do the same thing in your exam room. Do you feel like you're in a special place doing special things there? So think about that. Start there. There's no sense attracting patients if they walk in your office and it's not a place that, convinces them they're in the right place. The website, SEO is everything. Be careful about claims made because they can come back and bite you. Post reviews, testimonials from patients. You have to ask patients for these. Digital marketing, pay-per-click, Facebook ads, doctor.com is a good resource in terms of getting your name out there on all the physician search sites like, I can't remember the names of them, but you want to make sure your information is good and your bio is good and you look good and your office looks good. We give lectures on a monthly basis. We're using Zoom for those now with COVID, but I think probably going forward, we'll continue to use that because it's working well. Webinars, so that people can watch them anytime. Word of mouth, chiropractors and therapists can send you some patients as well. What does the future look like? Well, a lot of people are going to start offering biologics, mainly PRP. PRP is going to become commoditized. Competition will be on price once this occurs. Successful practitioners will be different in some tangible way. So how will you differentiate yourself? Well, having research outcomes will help. If you're the only one that actually has real outcomes and nobody else does, if you do a better process that has a better outcome, that's going to help sell your product and sell you. If you offer a more stylized environment for treatment, convey that you know more than others. Team up with a larger organization and ride their coattails like Regenerative or some hospital program. Keep training and learning new developments in the field and make sure your patients know that you are. Advertise, website, talk, blog, Twitter, get your message out there. Always get asked how much to charge, graphically dependent. New York City has a different cost structure than Iowa. And the biggest thing is your perceived reputation. If you're perceived as the best and you have some experience behind you and you have some research connection, you've got some outcomes, you can charge more. Don't forget, dollars spent by a patient is indicative to them of perceived value. So they're happy to pay more if they perceive value in you. If what you're doing doesn't seem like it's any more valuable than what their orthopedist offered, for $200, then you've got a problem. You can't charge 500 or 1,000. So you have to differentiate yourself in your marketplace, and you must be perceived as the leader in your town for these services. Presentation to the patient. Well, I always find it's best to present the entire range of available options. More importantly, the current standard of care to treat their problems. So I always start my conversation with, well, the standard of care for treating you is a cortisone shot and some physical therapy. And often the patient's already had that or doesn't want that. So convey that your goal is to help them feel better first and foremost, not to do your procedure. Understand they may not be able to afford the regenerative options, so unless you have a plan B, this patient can be pretty pissed off and go out there and say, well, all he wanted to do was expensive stuff that wasn't covered by my insurance. Have a plan B that, well, you can't afford that stuff. Here's some other things we're going to make you feel better. So nice to have some regular services to offer as well. Get good at reading your patients and whether they need something more or not. Other pearls, don't present options to them. If they came to you for an opinion, give it to them. So if you start a conversation, well, we could do Prolo, or we could do PRP, we could do stem cells, they don't know how to make that decision, and they're going to pick the cheapest one. I mean, it's giving them too much information. They came to you because you're an expert. So you start the conversation, well, for your problem, I would recommend this because it's going to be the best at treating it and it's going to have the most long-lasting effect. Period. And stop talking. That's what they came to hear. Make it a therapeutic decision, not a financial one. And make sure to tell them if they're a bad candidate. Send them away. Give other options. Send them to a surgeon. They'll respect you for it. If you try and treat everything that walks in the door, it's not going to work for you. Cash patients demand more. Are you prepared to deliver? Set expectations accordingly. Don't make statements that will bite you later. Never promise success. That's up to how well their body can respond and heal. Many medical legal risks with providing alternative unproven care. Make sure that your techniques and your protocols are bulletproof, because if you have a problem, they're going to come back and look at those protocols and techniques. And if you have them, your protocol says do X, Y, and Z, and you only did Z, guess what? You're in big trouble. And lastly, pick the easy cases first. While you're still learning, get some confidence under your belt and get some success. Well, here we are at the end. Thank you so much for listening. I hope it was helpful. We're going to take some questions at some point. So until then.